Good morning, and thank you very much for this introduction, and thank you very much, LACNet, for inviting me here today to talk about PRRT. I hope I can developments and, first of all, fundamentals. So, as Dr. Cernin mentioned earlier, we've been doing this treatment in Europe for 25 years. So now, finally, the treatment is available in the United States, but there's a lot of knowledge that we have gained from previous experience with yttrium dotatate, yttrium-labeled peptide, and more recently with lutetium dotatate or Lutathera. So what do we know? First of all, we know that this is an efficient treatment. It produces decreases in tumor size, symptom relief, quality of life improvement, decrease in biomarker levels, if you're interested in those. It has an impact on survival. And we recently know, this is European knowledge that has not passed in the United States yet, but FDG PET-CT is an important prognostic factor for the duration of response to this treatment. Now, from the tolerability point of view, we know that this treatment is generally well tolerated. Acute side effects generally are mild. They may be related to the co-administration of renal protective amino acids, mainly nausea or vomiting, depending on which kind of solutions you use. Symptoms related to the treatment itself, mainly fatigue. And subacute effects on the hematologic function, so on the CBC, are generally mild and reversible in the large majority of patients. Chronic and permanent effects on the target organs, we frequently hear about toxicity on the bone marrow, on the kidneys, but these are generally mild if the necessary precautions are undertaken. Currently, the mostly used peptide is lutetium dotatate, and it's in fact the one that is approved here. So what is PRRT? It's a treatment which is administered intravenously, but prior to that, patient need to be considered eligible for these treatments. So there needs to be a pre-therapeutic assessment, so there needs to be a demonstration, histopathological demonstration of a neuroendocrine tumor, the demonstration by gallium dotatate or NET spot that the target of this treatment exists. And there needs to be also a pre-therapeutic assessment of the extent of disease. Then we can switch to the therapeutic phase, the administration of intravenous lutetium dotatate for cycles, generally intercalated by an 8 weeks interval, safety lab assessment during the treatment, and then the treatment is followed by the follow-up phase where the extent of disease is reassessed, both with CT or MRI and the NET spot. So what do we know about long-term toxicity? I would like to get this out in the open because this is something, for years, it has been the major concern against PRRT when it wasn't approved. So this is a collection of several studies that sum up to more than 2,500 patients, including both yttrium and lutetium peptides. So the two target organs for the permanent effects are the kidneys and the bone marrow. As you can see here, renal toxicity is more a problem or more of a concern with yttrium peptide. The incidence of severe end-stage renal toxicity with lutetium dotatate is really minor, less than 1%. Permanent effects like bone marrow insufficiency or secondary tumors to the bone marrow are very rare. They do not show differential incidence between yttrium and lutetium peptides, and their incidence doesn't seem to be greater than the incidence with this kind of cytotoxic therapies. So this is a breakdown of nephrotoxicity in the series of patients that I treated, 800 patients that I treated when I was in Italy, in Milan. So patients were treated with either yttrium peptides, combination of lutetium and yttrium peptides, and lutetium alone. And as you can see, lutetium alone was not associated with any severe nephrotoxicity as opposed to yttrium-based treatment. Now, we mentioned during the course of the morning that lutetium dotatate not only has a direct effect on the tumor size, but it has an effect on the symptom control. And several studies, including a post-hoc analysis of the NERO-1 trial, demonstrated that in several series of patients. So there's a beneficial effect on the symptoms associated with neuroendocrine tumor disease, the diarrhea, the pain, and this improvement occurs irrespective of the tumor shrinkage or of the response to the treatment. Now, there is an impact of this treatment on survival. This was demonstrated already in 2008 by the Rotterdam group, the Quekeboom and co-workers. So when we obtain disease control after PRRT, meaning that the disease stabilizes or responds to treatment, we have an impact on survival, on the overall survival. Now, what is the factor that impacts on the disease control? One of the major factors that has been demonstrated to be impacting on this parameter is the metabolic activity at FDG PET. This is something that is probably new or newer to the American community, but it has been demonstrated. This is a study that we conducted when I was in Italy. There are several studies also in Australia, in Germany. Patients who bear FDG positive lesions usually have a duration of response or median progression-free survival, which is shorter than patients who bear lesions which are not metabolically active. And this is an independent prognostic factor for this parameter. Now, everybody is familiar with the NERO-1 trial, and Jonathan Strasberg will probably address, who's the first author of this multicentric trial. The NERO-1 trial was the first international multicentric randomized trial of patients of lutetium dotatate versus high-dose octreotide in patients with small intestine neuroendocrine tumors progressing on standard dose octreotide. As you can see, and has been explained by Pamela Kunz earlier, patients treated with lutetium dotatate had a median progression-free survival which was not reached during the course of the study, which translated in a 75% decrease of the risk of progression and death just by being on this arm of treatment. So there was an impact on progression-free survival, an impact on overall survival, and although the study is not mature yet for the overall survival, the quantification of the benefit in terms of life, there was a statistically significant impact on that too. So this was conducted so this is a randomized study in small intestine neuroendocrine tumor disease, but we know that lutetium dotatate is efficient also in other categories of neuroendocrine tumors. First thing, the pancreatic neuroendocrine tumors. Studies from Italy, from Bonn, Germany, from Rotterdam, the Netherlands, all demonstrate that there is an impact on a favorable impact with objective responses in a consistent percentage of patients and an impact on survival parameters, both progression, duration of response and overall survival. And the same holds true for bronchopulmonary neuroendocrine tumors. Studies from Milan, Italy, where I was before, conducted with lutetium alone, yttrium alone, or combinations, demonstrated that especially lutetium alone was associated not only with a consistent objective response, but also the most favorable impact on survival. Studies from Bonn, Germany, and from Rotterdam, the Netherlands. So they are all consistently showing a benefit in terms of response and impact on survival parameters. So a few years ago, we, a group of experts, reunited under the auspices of the International Agency of Atomic Energy. We produced a guideline document which was endorsed by the European Association of Nuclear Medicine and the Society of Nuclear Medicine and Molecular Imaging. We indicated that this treatment was indicated for neuroendocrine tumors, mainly of the gastroenteropancreatic and bronchial tract, ideally in NET G1 or G2. Now, we all know that the Lutathera has been approved both in Europe by EMA and in America by the FDA for gastroenteropancreatic neuroendocrine tumors. Now, as many of you know, a few days ago, NCCN met and produced a new guideline where actually, and rightfully so, PRRT is suggested to be considered not just in gastrointestinal neuroendocrine tumors or pancreatic neuroendocrine tumors, but also in bronchopulmonary neuroendocrine tumors, both typical and atypical carcinoids, and also in unresectable or metastatic pheochromocytomas and paragangliomas. So this is something that we will have to address as a community for the implications, logistical implications. So now, I like to show this chart to show where we started 25 years ago and what was the appreciation of PRRT back then. So at the time when we started, it was, of course, a treatment which had not been experimented for that long. So the strength of recommendation could be considered as an expert opinion, and it was considered by the oncological community as more like as hearsay. Then we progressed with cohort studies, and then, well, not very effective. Efficacy has to be proven in a randomized controlled trial. Yes, now we have a randomized controlled trial. Before the end of the randomized controlled trial, concerns were mostly focused on the potential toxicity. Now, finally, PRRT is the therapy for neuroendocrine tumors. But what now? What do we need to do now? So there's a lot to do. First thing, we need to be able to use this treatment also in bronchopulmonary and neuroendocrine tumors and in pheochromocytomas and paragangliomas. There are new trials underway. Some are randomized trials, some are non-randomized in other gastroenteropancreatic neuroendocrine tumors, in bronchopulmonary, in pheo and paragangliomas. There are new strategies that have been attempted, and they need to be validated, like combinations, intra-arterial treatments, new theranostics like the antagonist, somatostatin receptor antagonist. And of course, we need to go towards personalization. We have a fixed treatment, but patients have differences and have different sensitivities and different levels of tolerability. So we can adapt treatments on the basis of risk factors, on the basis of the FDG, avidity of the lesions, of the symmetry, but also we need to understand whether we can predict this, and we will see that if we can predict the specific response of that patient, of that tumor to the treatment. So, new randomized controlled trials and other trials. I would like to mention the COMPETE study, which is a study, a randomized controlled trial of lutetium DOTATOC versus everolimus in gastroenteropancreatic neuroendocrine tumors. Don't ask me how the acronym has been derived, but it's shown here. It started in Europe and is about to start very soon in the US. New strategies, especially the Australians were very strong in combinations with capecitabine, with temozolomide, with capecitabine and temozolomide, with everolimus. They all show very favorable results, but they're still, the series are underpowered, so we need adequately powered prospective trials to understand whether this is a viable option or a more favorable option for our patients. At the moment, we have new combinations with checkpoint inhibitors in high-grade neuroendocrine tumors underway. Intra-arterial PRRT is another very effective treatment. This is the first, how can I go back? Like this. Okay. This is the first experience by the group of Heidelberg showing that this strategy of inserting intra-arterially in the liver for liver-dominant disease, this treatment was very efficient. 60% objective responses is quite a lot and quite impressive. However, this treatment is still probably for the logistical complexities is still not fully explored. And it is, of course, primarily indicated for liver predominant disease. There are trials ongoing, for example, at UCSF, trials soon to be started, for example, at Memorial Sloan Kettering. Somatostatin receptor antagonists, they are sort of cousins of the Lutathera that we are using right now. They don't internalize inside the tumor cells, so they are not transported into the tumor cells, but they accumulate at the tumor site so much with very low accumulation in the normal organs, for example, in the liver, in the spleen. And there was a study which was conducted at Memorial Sloan Kettering under the foundation of the Net Research Foundation. And this study studied 20 heavily pretreated patients. 14 completed the 2 intended cycles of treatment. It's remarkable to note that disease control rate was very high, 81%, including 37% partial response and 47% stabilization of disease. There was some severe toxicity in the first, in 4 patients treated with the 2 full cycles, but a modified protocol with reduced activity per cycle allowed us to complete the protocol with no further toxicity. And of course, the remarkable objective response, for example, here you can observe a complete response. This is the CT scan. This lesion is present at the baseline and it's completely disappeared at follow-up, and this was the baseline accumulation at the imaging with gallium-68. So this is promising for the use of lutetium DOTA-JR11, and in fact we have a trial, a multicentric international trial to evaluate the safety and efficacy of lutetium DOTA-JR11, which is the name of this radiopharmaceutical. This has started in Europe and Australia and is about to start in a few days in the US. So now, therapeutic optimization, how can we do better for our patients? I mean, I've treated 1,000 patients with PRRT, but the question is, how can we do better? How can we improve the efficacy of the treatment that we administer? How can we improve the tolerability? So, first thing, many things can be done. For example, we can adapt treatment or intensify treatment according to the FDG status, as we discussed before. We can adapt treatment according to dosimetry. Dosimetry is a way where we calculate the radiation dose that we can deliver with the treatment for the tumor lesions and for the normal organs, so that we can establish the amount of radioactivity to be administered in the patient according to the specific burden. More like just when you do external beam radiation therapy, you do a calculation of how much you will deliver. So theoretically, this is advantageous, but unfortunately, it really looks like so much ado for nothing, because all the studies that have been conducted so far show that, yes, it's feasible, but it's very complicated for routine administrations, and there is no exceeding of safety limits for for example, for the kidneys in the majority of standard treatments, at least. This is not precise for the bone marrow dose, so at the moment we need some fine-tuning before we can use that. We can adapt the treatment according to the risk factors. If a patient has a compromised bone marrow function from prior treatment or renal function for prior treatments or prior conditions, we can adapt the treatment. This is something that has been done in Europe and is allowed also by the latitude of the approval of this Lutathera treatment that we have now. Another thing that I wanted to show you is how to adapt and personalize the treatment according to the genomic characteristics of the tumor. How can we accurately predict the response to PRRT? Everybody knows that net spot is the mainstay of Lutathera because you demonstrate the presence of the target, and according to the level of the presence of the target, which means the intensity of the uptake or the SUV number that you can read in your scans, you can understand whether the treatment is indicated and how much radioactivity it will be accumulated during the scan or when you switch to the therapeutic agent during the therapy. These are 3 patients with the same very high uptake, Kettering grade 4, in these tumor lesions, and yet they all get different results. We all have a number of very intelligent strategies. And we know we have surgery first. We have chemotherapy. We have very intelligent biological therapies. We have liver-directed therapies. We have PRRT, all of which are very clever, but they can be relatively inefficient because there is a lack of a molecular predictive strategy and a way to stratify patients objectively. So let me take a step aside and let's talk about penicillin. You know that penicillin was discovered by Sir Alexander Fleming, who together with Chain and Florey was awarded the Nobel Prize for the discovery of penicillin. So penicillin and other antibiotic therapy nowadays is currently administered, but nobody would ever dream to administer a treatment without testing the sensitivity to this antibiotic therapy. So this is a strategy that is a standard in infectious disease, but for some reason, apart from Jonathan Strasberg will tell us about temozolomide and the way to predict the response to temozolomide, but it's done very little in oncology. So what are the current strategies to predict or prognosticate the response to PRRT? We can use the FDG PET-CT, the performance status, tumor grade, extent. These are all prognostic factors that probably, irrespective of whether we give PRRT or not, will tell us if a patient will do worse or better on this treatment. We have the somatostatin receptor expression. We know that somatostatin receptor expression predicts the response to PRRT. So if a net spot is intensely positive, there's a good chance that this patient will respond to PRRT. However, even if you have the highest uptake to the net spot, only 60% of these patients will respond to PRRT. So we need to switch from therapy monitoring to therapy prediction. So from seeing after the fact what we have done to see before the fact what we can do. At the moment, we only have 2 monitoring tools. One is anatomical, CT or MRI, and the other one is molecular to see the expression of a receptor. However, the neuroendocrine tumor cell is much more complicated than that. It has a genomic drive of proliferation, of cell death resistance, of angiogenesis induction, of secretory production. And if we use a test, which is a genomic test, the NET test, which in 51 marker gene encompasses all these characteristics, we can perhaps better monitor our patients. I'll show you a case of a patient with a small bowel neuroendocrine tumor. after treatment, gallium net spot completely negative, but the NET test was highly elevated, and because she had cholelithiasis, she underwent surgery with cholecystectomy, and the surgeon agreed to do some random intraoperative needle biopsy, which was positive for neuroendocrine tumors. So we can actually see something that we don't see with imaging thanks to the NET test. So this can help us to monitor patients, including PRRT. But how can we move forward from that? I conducted, as a PI of a study multicentric in Meldola, Italy, Professor Giovanni Paganelli, Rotterdam, the Netherlands, Professor Krenning, and Bad Berka, Germany, Professor Baum. We applied the NET test in these patients, and we noticed that patients who responded to PRRT tended to have high expression of circulating genes in the blood, which were involved in the metabolic activity of the cell and in the growth factor signaling of the cell. So patients at baseline, before doing the treatment, had elevated growth factor and metabolic gene transcripts. So then we derived a predictive biomarker, because we took this metabolomic and growth factor signaling, we integrated this with a Ki-67 index. So we have a pre-PRRT blood signature, high versus low, a grade, Ki-67, as we discussed before, low versus high. With a logistic regression, we have a predictive quotient, or a test with a binary output, responder or no responder to PRRT. This is before PRRT. And this is what we get. So these are the responders, predictor responders who really are responding to PRRT, and these are the predictor non-responders who really do not respond to PRRT, unfortunately. So this is the result of our study. Recently published on 158 patients. These are the patients predicted to respond to by our pre-PRRT test. And these are, unfortunately, the patients predicted not to respond to PRRT. There's a very neat separation between the two curves, meaning that we can separate patients who respond from patients who do not respond to PRRT, and we can do that with an accuracy of 95%. And we also demonstrated that this is a real predictor because this test only functioned for PRRT and not for other things. When we apply the same test to patients treated with somatostatin analogs, or to just followed up with a watch and wait approach, there is no clear separation. The progression-free survival is just about the same. So this test is specific for PRRT. So in conclusion, PRRT has been accepted by the oncology community finally, and has been incorporated in the clinical algorithms of the major scientific society. It is now FDA and EMA approved for gastroenteropancreatic neuroendocrine tumors. Further studies are required in various clinical scenarios to establish the position of PRRT in the treatment algorithm. However, we must ask ourselves, do we really need so many randomized controlled trials? Can we do better? Molecular genomics is required to predict and define the efficacy and tolerability in conjunction with imaging. And this is a crucial issue in order to offer a better cure for our patients in view of the complex therapeutic algorithms that they will undergo during the lifetime. And with that, I thank you very much for your attention.